very good afternoon. This would be a wonderful auditorium if we were still needing to socially distance, wouldn't it? But luckily we can still be a bit closer to each other. If anyone wants to move in, you'll get a better view of proceedings if you do move in, but if you want to stay where you are, equally, please do that. It gives me great pleasure to welcome you here to the session called Challenging Beliefs and Perspectives in Obesity Management. My name is Lloyd Bracey, and I am delighted to be facilitating what promises to be a very lively session. We have a fantastic panel. If you were here a few moments ago, you will have seen them just going through their paces for the last moments of our rehearsal, but we'll reveal them in due course. And now, we would like you also to take part in what goes on here today, so please use every opportunity to get involved. Your chance to challenge the experts, if you like, to share your experiences also, and get involved by either going to, there are 2 microphones, so if you want to, when the time comes, go and approach a microphone, and I will make sure that you are heard. Or the technological way to do it is using the QR code that you will see in a moment, where you can scan the QR code, which will take you to Slido. We'll be doing that in just a moment. Have a little practice. So the key objectives of today's session, there they are on the board, which is to we hope that after this symposium, you will be more confident in choosing obesity management strategies with individuals that improve their health and well-being, and in developing obesity treatment plans that are sustainable for individuals over the long term. Now, to help us do this, as I said, we're going to be joined by a panel. There they are. We don't actually need the pictures because we've got the real people in just a moment. And there are their disclosures. Now, we hope that you will find this a very different format from the traditional symposia that you may have been to. Because in a moment, we're going to be hearing directly in person from someone who has been living with and is living with obesity. I have some questions for her that will raise some important matters in obesity management, and then we'll ask our experts for their thoughts on them. So as I said, we'd like you to be part of this, and there somewhere is the QR code, the quick response code. Who knew that that's what QR stood for? Please scan the quick response code, and it will take you to Slido. And if you've been to conferences and congresses, you're probably already familiar with Slido. It will invite you to connect and log in, and then you can put to your questions. We also would like you to make sure that you can, where possible, but don't be afraid to use those microphones. So your views, please, because this is, yes, we'll be hearing from experts, but there are clearly lots of experts here that we want to hear from too. So let's see how the Slido technology works with a warm-up question. There's always a warm-up question. Would you mind, please, scanning that code and seeing where it takes you? You should find yourself on Slido and follow the instructions. It's all designed for maximum simplicity. And let's see for a moment then, once you're doing that, here is a question to warm us up. Let's find out who's in the room, not specifically by name, but by specialty. So would you mind, once you've got yourself on something, we've got some very early runners, once you've got yourself there, could you just answer, which is your specialty? Are you other? Are you an endocrinologist? Are you a dietitian or nutritionist? Primary care physician, for example, a family doctor, or a surgeon? Have we covered? Well, others seems quite a large category there, but fine. So we know the technology is working. That's great. We've had the first question. Let's, oh, it's still changing? Still changing? Okay, we've got a good sense. Here's another question then I'd like you to answer. Using the same method, please could you answer the question, how confident are you in developing sustainable weight management plans for individuals? Are you very confident, slightly confident, confident, or not very confident? Okay, and once that settles down, well, in fact, it's a dynamic thing. It may not settle down. We will return to that a bit later on. Now remember that this program is, another question before we go on to that one. Here's another one. How confident are you in addressing mental, physical well-being as part of obesity management? Usual range of options: very confident, slightly confident, not very confident, and so on. Thank you for your responses. It's obviously the technology is working. As I was saying, this session is accredited, and so you will be able to get your CME award by the following methods. Virtual attendees can claim their credits by completing the evaluation form via the link provided on a different QR code at the end of the session. Right, those are the kind of housekeeping-y things. Now let's get on to the main session. As I said earlier, we are very privileged to have with us a person who has been living with, there we are, that's the information I should have clicked to. I'll give you a second to take that in. It's accredited by IACME for 1 ECMEC, and that's what you have to do to receive your certification. Thank you. So on to the main discussion. We're going to start by hearing directly from a person living with obesity who's kindly agreed to share some personal insights with us. From Ireland, please welcome a patient representative with the Association for the Study of Obesity in Ireland, the acting chair of the Irish Coalition for People Living with Obesity. Let's meet Susie Birney. Susie, hello.
How are you?
Thank you. You've been having a busy Congress, I think. You've been
I have.
running around all over the place. Thank you very much for coming to talk to us. I would like to ask you some questions which will raise points which we're then going to ask our panelists to address a little bit later on. Let me begin by asking you, first, can you give us, inevitably, briefly, the summary of your obesity experience so far?
Briefly?
Yes.
Okay, so I grew up very fit, very sporty. I didn't start gaining weight until my teens, but from an early age I had a food disorder called ARIFID, Avoidance Restrictive Food Intake Disorder, which wasn't added to the DSM till 2014, so it wasn't widely known. So that started, I suppose, the change in my life, in that everything was disordered eating, and then people would say, can you not eat normal? So I didn't feel normal. And that was before even obesity.
And how old were you then?
Oh, that started when I was 2.
Okay,
yeah.
Very early.
So I didn't start gaining weight till I was about 16, and I really focused on that. My food disorder was the only problem I needed to fix for my weight. I would have gained 2 stone, lost, 3 stone, gained up and back for years. But my weight didn't impact on my health. I was very, very fit and healthy. I would swim 4 days a week. It didn't stop me living my life. Stigma, now that is a whole different story. That was, always throughout when you're in a bigger body. But all of a sudden in 2009, when I was 35, I went from being healthy with a healthy BMI, no high blood pressure, weighing 25 stone, I think that's 155 kilos maybe, to very bad health. Type 2 diabetes, polycystic ovaries, a multitude of things happened all in 1 year. And then I needed intervention, and I needed it quickly from having needed no treatment for obesity before then.
And in essence, the interventions were?
I was referred to the weight management service in Dublin. And
you ended up with surgery too, didn't you?
Yeah.
Yeah, okay,
Yeah.
Well, thank you. Now, let's explore some of those things that you've been talking to us about then. For a start, let's talk a little bit about the impact on your overall health and well-being. You've touched on it, but we see a very, clearly an active person here before us today. What's been the impact on you?
Well, the impact, again, is this to be brief? Is it psychological or is it physical? Because it was both. Psychologically, that was the stigma you were dealing with, and that had a lot of impact. I had no self-esteem. Somebody made a comment of, why do you care about when somebody on the street does a double take when they see somebody in a body of your size? I didn't care what they thought, but it reflected what I thought about myself, that I actually disliked myself because I believed I had got myself into this state. Physically, I was in pain, but I was quite mobile, so people didn't understand that you can be fit in a bigger body. I went to join a gym one day, and you have to do an initiation. And the guy said, I want you to bend and touch your toes. Now, don't hurt yourself. Get past your knees if you can. And I placed the palms of my hand on the floor at 25 stone. He was shocked, because he judged me based on my body. So the impact of living in a bigger body and having obesity is huge, but you don't know it at the time if you don't understand what obesity is.
And you try to find things that will work. Which aspects of that search for a remedy were you finding the most challenging?
As I said, I really fixated on the food disorder. But when I went to the weight management service, I thought the psychology department was going to help me. And I actually got the most out of the physiotherapy. Okay. When in actual fact, I thought that being sporty wasn't a problem. So I think actually there's no one focus. I think anybody who needs treatment for obesity needs a full multidisciplinary approach, because you don't understand that one part of that multidisciplinary team has done you some support that you don't, has created a support for you that you might not understand has worked for you.
And during this time, you're coming into contact with a lot of healthcare professionals. Mm-hmm. I mean, how supportive were they?
Most of them were very supportive, certainly in the weight management service. But what was very difficult was that my treatment for diabetes and my treatment for obesity were in two different services. So I had to go to Beaumont Hospital for my diabetes, but the weight management for my weight management. And I actually went to a women's clinic for my polycystic ovaries. I didn't understand any of these were connected at all. So I in my head treated them very separately. I could go through a phase of only focusing on my diabetes, watching my HbA1c, checking my bloods, but not thinking about my obesity. Or then for another spell, summer is coming, you hated having to take off your heavier clothes that you hid behind. I would focus on my obesity and forget all about my HbA1c. I didn't make any connection between all of my health conditions until I started to learn about obesity.
Now, let me ask you a little bit about the treatments and the extent to which they have met your expectations. How prepared were you, for example, for the possibility of a weight gain after bariatric surgery?
I was prepared because I was in a support group, but I know many people aren't. Expectations are one of the hardest things to manage. We see it in the support groups all the time. People think they just need to be fixed, and I'm being referred to a weight management service. They're going to help me find what the problem is, and I'm going to be fixed. There's no one fix. We've learned that, you're going to need treatment for life. My expectations every time I went on a new treatment were incredibly high. But I didn't have bariatric surgery for weight loss. I had it to treat my diabetes primarily because I was terrified of the effects of the diabetes. So the expectations are hard to manage, but access to care, I suppose, is one of the problems because it's hard to get bariatric surgery, which reversed my diabetes on the day that I had it. So it should be accessible.
On the day? On
the day. I'm off all medication from the day I had my bariatric surgery in 2015. I'm monitored every year. There has been no sign of it returning so far. And I can't even put into words the relief of having treatment for the diabetes. The weight loss was an added bonus after that, but not the focus.
Talk to us a little bit about Susie today. How do you help to overcome that daily challenge of living with obesity as a chronic disease?
I think coping mechanisms and acceptance.
Coping mechanisms,
yeah.
Example?
I suppose not reacting to stigma in society was one that was very hard. With my food disorder, I had to certainly have coping mechanisms. I would never have come to a congress like this because I can't eat like everybody else. Now I've just planned, I accept. The longer I tried to battle it, and that word battle I hate when it comes to obesity because it's like as if you're trying to win something, the harder it was. As soon as I accepted it as a chronic disease, then I knew there was a treatment there and I just needed to get that treatment. Now, access is a different thing that's not in my control, but accepting that I needed treatment took away all of the mental anguish, the tiredness you got from getting up every day thinking, I need to try and beat this. Instead, I live with it, and that's the terms we use. I live with obesity, but it needs treatment.
A final thought from me for the moment, a real journalist question, but what's your view of the future? Are you an optimistic person as you look forward?
I am optimistic, but I think we all have to play a part in changing this narrative. We're sitting here at a congress and we're all fairly much on the same page. We've got to get outside of this bubble and educate society, educate healthcare professionals. We've got to let people know why it's a chronic disease, not just say obesity is a chronic disease. Why is it a chronic disease? I am optimistic. I'm fascinated by all the treatments that are coming down the line, but access, again, is a huge issue.
Well, no one could say you weren't being an advocate for your cause, Susie. Thank you very much for speaking to us for a moment. Now, I mentioned... Yes, thank you. And please stay with us. Susie knew she was going to be staying with us. I mentioned that we were going to be hearing from some expert panelists. It's time now to meet them. Our first panelist is co-director of the Metabolic Medicine Group at University College Dublin in Ireland, Carel Roux. Carel, hi, please have a seat.
Thank you.
And we'll be hearing from them all in just a moment. Now, our next is a medical doctor and a professor of nutrition at the Pitié-Salpêtrière Charity Hospital in Sorbonne, in the University of Paris. She is Karine Clement. Thank you. Next, we have an endocrinologist, a diabetologist, a nutrition expert, and clinical hypertension specialist in private practice, who also has a teaching position at the University of Tübingen in Germany. He is Stephan Jakob. And finally, and we put him last in the row because we were worried he might have to run here to get from another meeting, but luckily he hasn't had to do that. He is a Professor Emeritus of Medicine and past chair in obesity research and management at the University of Alberta in Edmonton, Canada. He is Arya Sharma. Welcome all, and thank you again very much for being with us. Now, you've been sitting there patiently, I know, listening to the points that Susie's been making. I know that a lot of what she says will have resonated with you. So let me ask you specifically about some of her points. And Stephan, if I may ask you first, in your experience, how common is it that people do have this significant health decline, as Susie did, despite the best efforts with lifestyle interventions?
Oh, I think it's very, very, very common. It's even more common in Germany because we don't have weight management centers disseminated all over Germany. And we are so much focused on the symptom like hypertension or high glucose, and we treat sugar, we treat blood pressure, but we forget about the roots.
Okay, thank you. Now, Karine, Susie also mentioned that it was the interaction with HCP, supportive, but not necessarily completely understanding her disorder. What's your advice to HCPs who just don't have all the answers?
No, I think it's a very important point Susie mentioned, and it can be also about stigma. And when you look at basically people asking questions about obesity or people going to an hospital, the main problem is that stigma and stigmatization can come from healthcare professionals. So there is really a great challenge to educate people, and that's for the good of the healthcare professionals and for the patient per se.
Carel, Susie said that she was prepared for the weight gain after surgery because she knew, she was informed. But in a few seconds, it must be a bit of a low moment for people who think this is going to be a good cure for them, and it turned out not to be.
Yeah, that's absolutely right. And if we have great treatments coming along, but if we over-egg the pudding, if we pretend that this is going to solve all the problems, then people are bitterly disappointed, when this happens. And Susie referred to the surgery putting a diabetes into remission. And that's normally, your most wonderful moment. The worst moment, however, is, heaven forbid, if the diabetes relapses. So we need to make sure that people are prepared, that they know this is a complex and chronic disease, but that we can help them and they can return, to centers for help.
Arya, so this question of physical activity after surgery, because increases in pain, access and so on, what do you think is key to the sustainable treatment plan?
Well, obviously, physical activity is important for, not so much from the accent that people often think that physical activity is important so that you can burn calories or you can burn off some of those extra calories, when actually that's not really the role of physical activity at all. Physical activity has a huge impact on other aspects of health, everything including mood, quality of sleep. It affects the immune system. It affects, it affects so many things and improves the lives of so many people. And it's not about burning calories. So I think, whether it's post-bariatric surgery or even for someone who's, who has not had bariatric surgery, I think understanding that there is a fundamental role for physical activity, but it is not about burning calories.
Thank you. Now, we've certainly set the stage with some thoughts to explore, so it's time to explore them. I've asked all our experts here to speak for 2 minutes on their particular aspect of their particular interest in obesity. I've also asked them to tell us one key thing, one key change that they would like to see, as I like to put it, on the Monday, when they get back to their clinic, to their practice, to see their patients. What's the one thing, the message that they would like to get beyond the walls of a meeting like this, where after all, as Susie has already observed, people know the issues. What's the thing that you could do to make the maximum difference? And I'll be asking them all to give us their thoughts on that and asking you to think which is the most important of them. That's to come. So let us start then with a brief discussion and a presentation from Arya, who is going to talk about stigma and bias by healthcare professionals. Is it still a major barrier to effective treatment, and how can we overcome it? I'll give him the slide advancer, and Arya, the floor is yours.
Yeah. Well, I think I can do the seeing down. So the first issue I really wanted to talk about is the whole issue of what weight bias, and we've heard this from Susie, that she was actually quite fortunate that, at least in the weight management service, if that was my understanding, was that she actually did meet professionals who, took a professional attitude. But what we know from, what many patients have told us, and which I think sort of reflects the lived experience of most people, is that they often run into health professionals, and we see this a lot, where health professionals simply say, I don't have time to solve avoidable weight-related health problems. And the key word here, of course, is avoidable, because it puts this whole notion that it's your responsibility, you've been doing this to yourself, you're continuing to do this to yourself, and because you've done it to yourself, well, you can actually do something about it. And in fact, you must do something about it. And because people, when you think about the etiology of obesity, everybody is focused on, well, if you're gaining weight, you must be eating too much. So obviously the treatment has to be you have to eat less than before, which, I always say, telling someone with obesity to eat less is about clinically as effective as telling someone with depression, you know what, you just need to cheer up. It's not a treatment. So, I think you run into a lot of that. Now, there's another point, is that physicians, maybe because what they heard back in medical school, and I can be very honest here, what I learned in medical school about obesity was 2 things. First of all, being fat is not good for you. And secondly, if you meet someone who has excess weight, tell them to go lose weight. That was the extent of my obesity education. And I think, because there are so many conditions and situations that are related to obesity, it becomes very simple to then believe that any problem that someone with obesity presents in your clinic must be related to their excess weight. And so there is this notion that, well, you just lose weight and you will be fine. And what this actually means for the patient is that the doctor does not take the time, the doctor does not order the tests, the doctor does not even listen to the stories, and does not perhaps even consider that there might be other explanations for these symptoms. And that, of course, has a huge impact on healthcare and patients not getting the kind of care they actually need and deserve. And I think the third point is on the patient side. So we've heard the one about how Susie felt about herself and about going to the doctor, and that is again something that you very often hear, and we've seen this in the action studies that patients report, and this is pretty much international, that there's a huge hesitancy of actually seeking professional help and going to the doctor. Part of it is stigma, part of it is, well, I've done this to myself, I know what the problem is, it's because I eat too much, what's the doctor going to tell me? He's going to tell me to eat less, I already know that. And so there's an avoidance. So rather than seeking medical and professional help, there is a lot of this, I'm going to try doing this by myself. And that, of course, ultimately has a huge effect on success, because we do know, and we do have evidence, is that when patients seek professional help from professionals who actually know what they're doing and are not simply trying to sell, their bestseller book or a supplement or a quick diet or whatever program they have, the outcomes are, in fact, better. They're not optimal. We have got a lot of room for improvement as far as obesity management is concerned, but there's no question at all that the evidence supports that multidisciplinary teams with professionals who have the knowledge and who are trained in obesity management will always do a much better job than trying to do this by yourself. How can we overcome the whole bias and stigma stuff? I think there are certain things we need to stop doing. We need to stop demonstrating weight biases by spending less time with people. We need to stop blaming patients for the problem. Using negative language such as the patient is obese. We don't say patients are cancerous or patients are arthritic or patients are demented. No, we talk of patients with dementia or patients with cancer. And in the same way, we need to stop talking about obese patients. We need to start talking about patients living with obesity. Focusing on weight is not very constructive. In fact, in my own clinic and in our, we try to not focus on weight. We try to focus on the actual behaviors, things that patients can do. And ultimately giving the same advice to every treatment. So a lot of weight loss clinics, they often have one program. They do claim that it is individualized, but when you look at what they actually offer, it's pretty much cookie cutter stuff. Everybody kind of gets the same thing, and we know that that's probably not the best approach. Here's what we need to do. We need to recognize that sustained weight loss can be difficult, and the reason for that is fundamentally biology. And a lot of our interventions do not change that underlying biology. And that is absolutely crucial for us to understand as the provider. It's essential that the patient understands that their likelihood of failure is largely driven because of their biology, which we are not changing through our educational activities, and that regaining weight actually is the reason that you need to come back and not the reason that you need to stay away. It's really important to listen to stories. Patients have stories. I've learned practically virtually everything I know about obesity just from listening to my patients. We need to use people first language. Even at this conference, I see that message has not gotten through to everybody. So a lot of work to be done there. And I think we need to focus our conversations about health and not about the weight loss. And obviously, if you've listened to previous talks that I've given, we always have to focus on what is really feasible for a patient given their circumstances, their situation, their socioeconomic possibilities. And these things can change over time, so we come back to the issue about having to listen to our patients.
Thank you, Arya. Any of our panelists want to? I wouldn't wish to deny anyone their applause. I'm sorry about that. Anyone want to come in? Yes, Susie?
When I said that my multidisciplinary team were very supportive, they were, but I did have a lot of instances in the healthcare that weren't, and I had to go for a kidney exam once, was told to fast from 8 p.m. I fasted from 6 because I'm a nervous person to get things right. And when I went for the test, the nurse was pretty aggressive, would be the word, and said that I hadn't fasted. And after trekking through the hospital to find a cubicle that I could fit in to give the urine sample, she was really irate with me. I didn't go back. She abandoned the test and said, I can't do this test, you're too fat, and left. Now, I mean, I can't lose the weight in a couple of weeks or even a couple of months, but I did get a referral letter back again, and I never went. I directly did not follow up on a healthcare appointment because I was so ashamed of how she made me feel. That was when I was about 21 years of age, and I would remember her now if I was to walk past her in the street.
It must have been a pretty low day for you then, as you left that appointment.
Oh, yeah. I actually don't think I spoke to anybody for 2 days. I didn't answer the phone.
Someone has asked a question here on the point of stigma. Shouldn't we rethink the definition of obesity, give it a less static view? What about that? Briefly.
Well, I mean, if I can speak to that, I think that's one of the biggest issues, right? Right now, we largely are using a size-based definition. Body mass index is a measure of size. It tells me how big you are. It does not tell me how sick you are. And in fact, it's not superior to a clothing size. If you tell me your dress size is a size 18, well, then you better go see your doctor. I mean, that's kind of the level that we're operating off. We absolutely need a better definition of obesity that makes a clear distinction between someone who's healthy and unhealthy. And we know from the data that does not always depend on your weight. In fact, you can find people at almost any weight who have symptoms that could potentially be improved if they actually had weight management.
Thank you, Arya. Let's go to our second question, because I'm conscious that we will keep on time so we can cover the maximum number of things. And that question goes to Stephan, and it is, how can management approaches be changed to prevent significant health decline in people living with obesity?
I need to get up.
You can.
I did bring a German guy, Mr. Miller. I wrote it in without the umlaut. It's Mr. Miller. He went to see his GP because his wife pushed him to go there. And that guy at the age of 30 had a BMI of 31.5. His blood pressure was 138/83. And the lab was some kind of normal. So he had his checkup for this. 10 years later, the next checkup. BMI went up 34, blood pressure went up, glucose was a little bit high, but he said I had a drop in the morning, so that's it, you know. And then at the age of 50, he had a BMI of 35, his blood pressure was even higher, and he had chest pain, and diabetes was diagnosed. What did the doctor say? Well, when he was there at the age of 30, Mr. Miller, the doctor said, hey, I wouldn't have expected that. I mean, he's so fat. And then, at the age of 40, he said, hey, you should stop gaining weight. Blood pressure is on the rise. Do something. This is what he just said, you know. And now you've got what we always expected and we warned you about. So this is the normal way in Germany. I think in your countries as well. They might speak different languages. Okay. So what could have happened if he had seen a doctor or someone who is a little bit more empathetic and who is more knowledgeable? I mean, the first contact already would have been the best way to address the risk. It would be the best way to offer support and to make it clear to this guy that he should not come up in 10 years. He should come back earlier. And then, if you catch him at the age of 40, you should say, hey, there's a problem there. There are several problems here. We need to tackle that. And I'm ready to help you. And offer support. He needs blood pressure control, but he also needs weight management support. And we have also anti-obesity medication. And if you had seen him at the age of 50, you need to really go for a good cardiometabolic risk management because that guy has severe problems already. And of course, we shouldn't forget about the weight. And Susie has very nicely addressed the issue about getting rid of diabetes. So we could, by bariatric surgery or by some anti-obesity medication, help this chap. So if we were to help very early on, and if also the patient could have been followed over the time, we would be able to tackle the whole risk. And maybe at the age of 40, he would still be of good weight, but without these risk factors. And maybe if he struggles with his weight, we would be able to support him by a prescription of a drug to help to modify the weight and to continue the weight management. But we all know that the people run off, trouble in their jobs, move to different places and so on. And then even if he comes back at the age of 50 and has more problems, we still have to focus because his knee pain and his blood pressure, you all know this has the same root. But for the knee pain, he goes to see the orthopedic surgeon, and you know what he says. You're too fat, you have to lose weight. I don't operate on you. This is the catch-22. So I think we as healthcare professionals, we should really know where the roots are for all these problems, and we need to always consider that together with the patient, because that guy already has a lot of pathologies, and he's running into major, I would say, cardiometabolic trouble, but the quality of life is also very bad. His knee problems are bad, so we should have really tackle the roots as early as possible. And unfortunately, as we are so much focused on single pathologies, blood pressure, oh, still okay. Glucose, oh, still okay. Oh, he's too fat, he has to do something. This is how we do it at the moment. Thank you.
Thank you, Stephan. Anyone else want to come in here and correct or argue with Stephan?
Well, there was a comment that Karine made. She said, well, but not in France. So now I'm curious. Now I want to hear what...
That was the German way, but
serious point underlying that. What's the difference?
No, it was a joke, but no, I agree. And I want to come back on education and maybe one very important aspect is probably, especially for medical doctor, to have this educational aspect, which is early, for example, for med school. So we need, for example, in our department, we have session with medical students, with patients coming over, and we ask questions about obesity, and then we can see if we address the question of stigma, how improvement it can be after when the young doctors are taking care of patients. So I think this is absolutely key. So act early with really an education way of teaching.
Your colleagues are nodding their agreement. Susie, yes.
I think you need to understand how hard it is on patients who regain, that it's harder to look for help the second time around if you've lost a vast amount of weight. My own GP said to me, I hadn't seen him in a couple of years, I had no reason to see him. And he said, would you mind hopping back up on scales? I see you've actually regained quite a lot of weight. I said to him, well, obesity is a chronic disease. And he went, oh no, that takes away personal responsibility. And I said, when have you ever known me not to take personal responsibility? And he said, but how did this happen? And I'm looking at him going, you're my GP. You know I have a food disorder. You know I came in to a referral for a CT scan on my knee because I have a knee injury. You know why. But yet he just looked at me and said, you've regained weight. And many patients in the support group say that they find it hard to go back to their team because they feel ashamed, because they've let their team down.
Again, we're getting nods of, I'm sure that's a common experience with others here in the room. I'm going to come to you in a moment, Karine, if I may. But Stephan, I'm now going to ask you, as I said I would ask everyone in due course, the one thing, your 10-second cure. What's the one thing that you would like people here today to go and spread, the word they'd like to spread?
I think you all know of it because you would not be here and interested in managing obesity if you were not interested. But I think we have to bring the message across that we really need, as early as possible, empathetically tackle the roots and see the roots. Like in this chap, I mean, if you see that guy at the age of 30, at least have a good and an empathetic talk to the patient. And talk to him, hey, you are on the way for hypertension. You're on the way potentially for further disorders. Let's do something now, because it's still at time. So tackle as early as possible, and don't segmentalize the symptoms.
Intervene early is your key message there. Thank you. Karine, it's your turn, if I may ask you. Finding treatments that work for individuals over the long term is challenging. How do you approach this in your practice?
So thank you, Lloyd, for this question. And I guess in this question, there are words. And I suggest we kind of dissect what the words mean. So finding treatments that works for individuals over the long term is challenging. So the first thing I think is, what are the challenges, actually? And what are the facts? And we've heard, and especially during this meeting here, that whatever we do, if we do weight loss intervention using lifestyle recommendation, pharmacological approach, bariatric surgery, we all know that there is huge variability in the individual response. And we had sessions about that, and we have sessions trying also to find the reason regarding this variability in the response. So it can depend on, of course, individual, clinical history, phenotype, biology, psychology, and so on. So there are many factors, and it's very difficult for clinicians to predict, basically. When we can look at surveys, lots of people, but when you are in the clinic in front of the patient, what can we do? We don't have cues. We can have ideas, but we don't have cues to predict what would be the answer. And this is a key point. The other, by dissecting this question, the other word is what does treatment means? So basically treating people with obesity. And again, and this is also linked to the previous discussion, we all know that it's not limiting to lifestyle changes or pharmacology or bariatric surgery. So it really depends on the person in his or her environment. So basically, we need to have a psychological evaluation, stress evaluation, behavior, social aspect, medical condition. We saw that with Mr. Miller. Personal familial history. We spoke about stigma. So we are with people with different individual objectives, patients with different phenotype. And when you look at this, you say, maybe I need also as healthcare professionals, maybe I cannot address myself all the different dimensions. I need to be in a team and have networks with people that can address the different dimensions. Another aspect in the question is about what does work mean? So this is the definition of success. And this is another aspect. So we spoke about weight loss related aspects. And okay, so what is the priority here? Is it to induce weight loss? Is it to prevent future weight regain? Is it to prevent eventually weight cycling, which we know it's very difficult? Is it to, as we just discussed, also speak about comorbidities? And maybe sometimes the priority is not to speak about weight. Maybe the aspect is, the first priority will be to deal with psychological aspects, depression, food intake disorder, behavioral disorders, and so on. So I guess a main message is what is the priority, especially when you see a patient for the first time. So that means that we need time. We need to have detailed evaluation of this multidimensional aspect, and probably with colleagues. And then it's a question of discussion with the patient. So we need to get a mutual agreement on the objective. So what is reasonable? What can be reached? Of course, and then there is a question of follow-up, and we all know, and there are very good examples of, a lifestyle intervention with great coaching, but can we really do that in clinical practice? But that's something you need to discuss with the patient. And sometimes a priority is number one priority, but it can change, and we need to review the objective. And then in the future, of course, we know that new drugs are coming, so there will be this aspect regarding the individual response to drugs. And again, we will need probably eventually to change drug depending on the response, and also decide, and that's another point that will come after, which drug for which person, but we'll discuss that further. Okay.
All right, thank you. Yeah. Again, any of our panelists here want to add anything to what Karine said? We'll hear from her again in a moment. You might be interested to hear, Susie, that someone has said that they know exactly how you feel because they went into treating people with obesity as a result of having had to endure what you went through on their own. So, it led to clearly someone embarking on that career. A note of hope. Let's talk about surgery, bariatric surgery. Carel, your turn. Now, it's associated with benefits, but also with complications and, as we've heard, with weight regain. So the question is, what role for surgery as the pharmacotherapies become more effective?
Yeah, Yeah, absolutely. And I think, this is a great conference where we have all of the professionals interested in treating obesity, including our surgical colleagues, together. And I think that's so important that we discuss these issues, because it's only when we're going to talk together that we will be able to find some solutions. There is, however, a word of caution. Because we are all as scientists here and clinician scientists, and we would like to think that each one of us practices evidence-based medicine. But let's evaluate the evidence here, and I'm showing you here the trends of bariatric surgery in the United Kingdom over the last 10 years. And you can see that the number of operations that has been performed has been pretty stable. Now let's superimpose on this picture at least the 13 randomized controlled trials that have been performed in obesity surgery and specifically diabetes surgery on top of the graph. And you may not be surprised to see that there's been no impact of this evidence on the clinical practice. But you will say, well, maybe all these randomized controlled trials were specifically focused on people with diabetes. So let's actually think about the evidence showed, and of course the one-year remission rates of people who've lived like Susie with diabetes and obesity has really been impressive, and each one of those randomized controlled trials showed the same data, that surgery was superior to the best medical treatment we had at the time. Okay. And even now we have 10-year data, so it's not only short-term data, it's long-term data that we have as well. So let's now evaluate what the impact of this level 1 evidence has been on the surgery of diabetes. So how many of us referred patients with diabetes to have surgery, given that we've had this evidence? And you can see on the left-hand side, I'm showing you the percentage of people having surgery that also had diabetes, and on the right-hand side, I'm showing you just the diabetes data. And I would be really disappointed to discuss this issue that despite the evidence, it did not change our practice. So now we're having great evidence coming from medication. So just because we have level 1 evidence, we should be concerned that that may not impact on what we do before. Now, you also were kind enough to answer a question in the beginning to say, what is going to be the impact of these medications that's going to lead to 15%, 20% weight loss on average? So imagine these are all the people living with obesity in this circle. What we know when it comes to surgery is that the penetrance is approximately 1% only. So that means 99% of people eligible are not actually receiving surgical treatment. Certainly in my practice, and it'll be interesting to hear about yours, there's many patients who come in that says, I do not want to have surgery. But they may be interested in pharmacotherapy. So let's just pretend for a moment that that represents 10% of the people that are now going to access pharmacotherapy. That's maybe a little bit positive, but I think, we may well get there. However, our best medical treatments, we know the average weight loss is incredibly good, but we also know that maybe 20% of patients who do not have diabetes and maybe as much as 30% of people who have diabetes and obesity may not have an optimal response to the medications. So that represents this circle. And you can see that the circle of people who are not responding to medication, but who may have engaged in treatment, now are going to look what's next. So I would say if you're a young surgeon, don't stop training. Because if we just transfer these people over to have surgery, what we may end up with actually needing more treatment. And that's what I would advocate for, is we need more nutritional therapies, more medication, and certainly also more surgery. So thank you.
Thank you, Carel. Thank you. Yeah. Arya, Stephan, what is the practice what do you find in relation to what you've just heard Carel say?
Well, so if I speak for Canada, we did see a quite significant increase in the access to bariatric surgery in some provinces. In some provinces, nothing has changed, and in some provinces, the access has actually gone down, over the past several years. And I think the whole story comes still down to this whole issue that bariatric surgery for obesity, both on the patient side, most doctors' side, and certainly on the payer side, is still something that is seen as an ultima ratio, which means it's the last thing you would want to do, and you would do it in a very limited number of people, and you would kind of do it almost as a desperate measure. And I think, Carel is absolutely right that the level of evidence that we actually now have in support of bariatric surgery in terms of its safety, in terms of its long-term outcomes, in terms of its regression of diabetes or putting diabetes into remission, has not really penetrated the consciousness of patients, of providers, and most importantly probably of the policymakers. And I think, unfortunately, that all of this comes back down to the first issue that we discussed, and that is weight bias. That as long as there is this pervasive belief that all people, that all someone living with obesity has to do is just stop eating so much and get off your butt, and you will be fine. As long as that is the pervasive belief in the system, we are probably going to find it extremely difficult to increase access to any of the obesity treatments. Fully recognizing that some countries are doing a lot better, if you take France, the number of surgeries, and if you compare that to Germany, Germany's doing, I believe it's almost a 10th of the number of surgeries that France is doing, and there's no real explanation for that.
I would say Germany is great in sugarology, because in the people with diabetes, we like to go for insulin therapy, because all the people living with obesity and diabetes would be at least eligible for treatment with GLP-1 receptor agonist. But you are punished in Germany if you prescribe too much of GLP-1, but you're kind of getting benefits if you prescribe insulin. So we have an extremely high rate of people with insulin treatment. So that is even counterbalancing all our efforts. And on the other hand, I must agree, unfortunately, Germany is doing lousily bad in terms of obesity management with any evidence-based proven therapy.
Interesting. Karine?
Yeah, I would like to add a quick note about bariatric surgery. So as you mentioned, Arya, so in France, we have been the top leader, population-wise concerned about bariatric surgery. So it was 60,000 persons per year going for bariatric surgery. And this is to some extent kind of a new situation, because we have people living with obesity, but also with bariatric surgery. Mm-hmm. And then there are issues per se regarding what is the next step and the next treatment, mm-hmm. and especially regarding new drugs which are coming. Mm-hmm. But this will be, again, another challenge, because what will be the choice? The situation, and to some extent, this had a new condition, a new situation to take care of.
Okay, thank you.
Yeah.
In the interest of time, I'm going to move on if you don't mind. But Carel, before we do that, I'd like to ask you for your magic action point with this pharmacotherapy surgery split in mind.
Yeah. So the magic action is follow the evidence, but don't think that the evidence is enough. We really need to address the emotional side together with the logical side to move the needle.
Thank you very much. Arya, coming back to you now for the second of your two presentations. Where's the...
Clicker.
The clicker. And the question here is enough being done to support people with the physical and mental challenges of obesity as a chronic disease?
Well, we've just heard, of course, that, and Karine has just explained very nicely that, we've had this increase in bariatric surgery worldwide. There's almost, a million surgeries that are being performed worldwide now. So there are a lot of people living with surgery, and surgery has not just happened in the last couple of years. Bariatric surgery has been going on, or metabolic surgery, if you prefer that term, has been going on for a long time. But we do know that obesity is a progressive relapsing disease, and first of all, bariatric surgery does not cure obesity. A lot of people who have successful bariatric surgery, still carry 80% of the weight that they had before surgery, and still have a lot of the comorbidities they had before surgery. They might have gotten better, but they're still there. And so really the question then becomes, how do we actually support these patients? Now, I think one of the things that we are missing in this whole picture is that we tend to focus our attention perhaps too much on weight. And obviously, there is an impact on weight, we know that, for example, physical activity, can be very weight dependent. But sometimes the best management strategy, and perhaps even the more effective management strategy, and I've learned this from physiotherapists, is not the weight loss, but are actually exercises that improve mobility and strengthen muscle and strengthen tolerance, and very often addressing some of the mental health issues, the depression that patients might be having, the insomnia that patients might be having, living with osteoarthritis might actually be as effective, if not more effective, than losing a couple of pounds. And so we kind of hasten, again, in our judgment of saying just because this patient has obesity, the best solution to all their problems is they need to lose weight. And we forget that there might actually be other treatments for this patient that might be as effective or at least as supportive. Now, 20 to 60% of people living with obesity do suffer from a psychiatric illness. And I just made the point in the earlier talk that I gave today is that most of us, perhaps because our backgrounds are in metabolic disease and endocrinology, maybe in gastroenterology. Just by raise of hands, how many psychiatrists are right here in this audience? Well, we've got one there. And you're actually here for the program. You're not just here for the free lunch. No, the point I'm trying to make is that we have not actually been able to engage the mental health community in getting them to take ownership for this issue. And in fact, it is actually one of the major rate-limiting steps in trying to get access to treatment, which as a result is that you now have a whole bunch of family doctors, learning and taking courses about cognitive behavioral therapy because I don't have anybody to send these people to, so I got to learn how to do it myself because that's the only way that I can actually deliver this to my patients. Now, one of the problems, that we do, on the other hand, often ignore is that there is surprisingly strong evidence that weight loss can actually improve the mental health aspects of people living with obesity. There is quite, I would say convincing data, but I know this from my own practice, is that one of the consequences of losing weight or having better control over your weight is actually that there's an improvement in mood, there's an improvement in self-efficacy, patients are much more active, people feel a lot better about themselves, and that of course reflects on their entire outlook on life, if you so will. And I don't think that the mental health community has embraced those possibilities that obesity management might actually have to offer their patients. We've seen data presented here on how important it is to address medication-induced weight loss in patients who have mental illness. That is a message that hasn't gotten through to most people practicing mental health medicine. So I think that's an important aspect. So this kind of cycles into this. And then there's the third aspect here that we have to recognize that even if you address the mental health issues, it's not a magic fix. And the relationship issues are there with depression, and all of these things can actually also in some cases be precipitated by weight loss. I've had patients who've had panic attacks after they've successfully lost weight. Just because they felt more vulnerable and and for patients where food is a coping strategy, if you take away their food, well, then the question is how are they going to cope if you haven't actually put something else in place or have, addressed that. So we have a certain level of complexity here that I think is not central to this discussion. And I would say if you listed all of the abstracts and all of the interventions, you would actually find that mental health is underrepresented, especially from an intervention perspective. And then before you ask me the question, I can tell you that my take-home message here is that if you are working in the field of obesity, and I don't care if you're an endocrinologist and the last time you took a history for depression was when you were in medical school, you got to, pull out those old textbooks and learn how to do it because you cannot claim to be an obesity doctor and not know how to take a mental health history.
Thank you. You did preempt me. That is indeed what I was going to ask you for your key point. Yeah. Any questions here from the audience as we move on through our session today with about half an hour to run, and I promise we will finish punctually. Anyone, if you do have a question, please feel free to come to the microphones to ask it, or indeed to continue to do as some of you have to send it through here. Right. Yeah, Susie, I beg your pardon.
Just to respond there to something Arya said, I brought my notebook with me because things come into me just as I hear them and I don't want to forget because they can be important. After somebody has lost a vast amount of weight, quite often we've read in the support groups that they don't know who they are. They don't know what their identity is anymore because they've lived as the fat person in their heads. And that's their place maybe in their group of friends. There's a lot of people end up separated from their partners after they've lost a lot of weight. And also just physically how, like, you know when you park your car and you think you can't fit between the two wing mirrors, and people who've lost a vast amount of weight still walk around the other way. And there's a huge adjustment. And I would actually think that mentally how you feel about your body and your weight is never physically where you are. Because before you lose the weight, quite a lot of people living with obesity don't really look in the mirror a lot. They maybe just look at their face until they see a photograph of themselves and they get a shock that that's them. And then they lose a vast amount of weight and they still don't believe that's them, and they go buying clothes and they're still buying clothes that are too big for them. So I think there needs to be a lot of mental health care following up for people after they've had treatment, and it should be ongoing anyway. But yeah, that just resonated with me there.
Good.
I think there's a question from the audience there. Thorsten.
A real human being at a microphone, please.
Thank you. Thorsten Roberts from Sweden. A great session. But I just wanted to comment a bit from Professor Sharma's comment about mental health. From our studies in bariatric surgery, and especially in adolescents, I think we should be very cautious in promising gains in mental health. Because we see this honeymoon phase over the first time when you lost weight, and we see those diverting. We now have a randomized studies showing that the intense medical and the surgical, they divert very much over the first year, but after 2 years, they come together again. Yeah. So just a word of caution, if you can comment on that.
So it's about management of expectation.
Yeah, so thanks a lot for that comment.
Thank
because
you.
I think it's essential that we understand that obviously after bariatric surgery, but that, by the way, this is not just bariatric surgery. This is also when you start someone on medication and they're having success, or you put someone on a low-calorie diet and they're having success. You go through this honeymoon period. It's almost a euphoric state of, well, my life is going to change, everything is going to change, and then you're going to hit the plateau at some point.
You're a maniac.
Right? At some point, you're going to stop you losing weight. It's usually at a point where you are wishing that it would continue. You don't stay at the nadir, and then the honeymoon period is over. You realize that some of the problems that you thought were because of your excess weight are actually not because of your excess weight, and you still have those problems. As Susie just mentioned, there might be new problems showing up in your relationship, in your job, in your relationship to others. And so thank you so much for that point, because we should not assume what will happen with the mental health state of someone who has lost weight. It can go either way. And it can change. You could be positive initially and it can be negative later, or it could be negative initially and it could become positive in the long term. So thank you for that comment.
I just want to add to that we always need to make it clear also to the people living with obesity that we need to stay in touch, because most of the people have one aim, to lose weight. And they lose 5 kilograms, wow, that's it, and then they disappear. And they are left alone. They won't come back because they are ashamed that they had regained the weight. So I think we need to make it really clear that this is a chronic coaching or support process. And then we should also hopefully be able to pick up all these mood disturbances.
Thank you very much, Stephan. Karine, we have a second presentation to hear from you, and I'd like to ask you to give it now, please.
Yeah. Okay, so times are changing. So have you noticed that? So there is this question about new drugs coming on the market, and then the question is, will new drugs lead to better outcomes or more challenges? Again, challenges. So again, what are the facts? So the field, and I think it's a good thing. The field is rapidly moving, and we recognize that there is a need for pharmacological tools. That's a fact. And then there are new drugs. So there are drugs now already available, and we all know that there are drugs in the pipelines. There is also the importance of future combination therapies, and I will come back on that at the end. And another very important fact, and I guess this addresses several aspects we already talked about, is that the weight reduction, even if modest, will improve comorbidities as well as quality of life, right? So, and we spoke about that. And even in some cases, decreases mortality. And we heard also during this meeting that we all think about, precision treatment. We call personalized, but now the new word is precision. And actually, there are already examples of precision medicine. And this is the case of rare genetic obesity. And actually, at the same time during this session, there is a parallel session on this specific topic, where and we have, and that's very interesting because that's also that's scientific and also a personal history with patient, where we have this opportunity indeed to give a great service to people with monogenic form of obesity, because now there are new drugs. So these are the facts. And then the other aspect is, what are the challenges? Of course, we have new drugs on pipelines, and I guess there are challenges that are just due to new drugs, so which are benefit-risk evaluation. Of course, those arising in medical treated chronic disease. And we will have to rethink, because for years, it was like the no man's land, right? So we had barely, basically no drugs. So we had to rethink about that. So what is basically the adverse effect? What about adherence to treatment? What about future drug combination and so on? So this is going to come back on the field again. And then as a future challenge for us, and all, I guess, people in this room, is which drug or combination, and again, when to give drug, for whom, for how long. So we need to have wise prescription. I won't detail, but we had, to some extent, with some drugs, I would say so-so experience, where, it was like the same drugs for the majority of persons. So, and we need to keep in mind those difficult experience. I say difficult for the field. And then another challenge that will come is we spoke about during this meeting about precision approaches in obesity management. And I just mentioned the fact that it's already possible in genetic form of obesity, but in the future, we have to work on that. And this is a work to do, is really which condition, which person, which drug, and also it can change with time. And finally, and it's a very important challenge too, it's the economical aspect, just because of also the prevalence of obesity, and also because we acknowledge that it is a lifelong treatment. So I don't have all the answer, Lloyd, but next year there are challenges. And I just want to add, to finish with that, so don't be afraid, I am not going to detail all pathways involved in obesity and in the complex pathophysiology of obesity, but we all know that there are aspects regarding, of course, neurons, food intake control, energy expenditure, but we should not forget about the peripheral system, and there are links and networks between all these systems. So in the coming years, we will have, as I said, new drugs coming in the pipeline. But what I like here is that with new drugs, we learn about the pathophysiology of the disease. And that's well known for hypertension, for example. There are a number of drugs. But because people who have to treat for hypertension, they learn about the pathophysiology. And I think what is positive here is that with the new drugs coming, we will, health practitioner will learn about the pathophysiology, and I think it's a good thing. Yeah, I'm going to stop here.
Thank you. And let me ask you then, Karine, very finally, for your action points. What's your magic solution?
You mean for
the whole problem that we're talking about today? So, 10 seconds.
So, 10 seconds. I think we need to. Well, we spoke about we use this word holistic approach. I think we all agree about the complexity. But within a holistic approach, maybe regarding the first consultation, I think the question to ask is, what is the number one priority in patient care? And that's really the question each time for consultation we might ask. Number one priority, and it can change during the patient follow-up.
Right. Thank you.
There's a question.
Yes, I've seen it, thank you. And we did, in fairness, in full disclosure, I did give our 4 panelists notice of that question, so we'll be coming back to that in a moment. Yes, we have another question, please.
Nick Feiner from Denmark. Susie, it's a question to you. We've heard from Karine about new pharmacotherapies which are already here and those are coming, but we know that the stay time of patients living with obesity on anti-obesity medications is 60, 90 days. And I just wonder if you could give some insights as to what you think lies behind that challenge of getting patients living with obesity to stay on medication for long enough.
I think many patients give up on treatments because other treatments in the past haven't worked for them. I don't like to use the word failure or success anymore with treatment for obesity, because I think we discussed this earlier. What is success? What Carel would think is success would be a percentage, but patients want it all, that they feel they have to have it all. So I think living with obesity is so hard and you're so broken at times, you need that quick fix. So if you don't see it happening, and you see the problem about patient support groups also is that patients compare to each other. And they see it's worked really quickly for somebody else. And why has it not worked for me? So they give up because they think it's not working. I think there's an analogy I think of with obesity treatment for me that it just makes sense, that many patients seem to think that it's like going on a car journey. It'd be like going from Dublin to Cork. It's 3 hours on the motorway and it's one way and you get there. And that's what they see. Either it's pharmacotherapy or it's surgery. When really you go on a windy road that could take 5 hours to get there. You may need to stop and ask somebody for help. What way do you go? But they might give you the wrong direction, so you have to ask again, or you have to check your sat-nav, and you go over a speed ramp, and you have to stop at the crossing of a train going by, and there's a barrier there for you to get where you're going, but you'll get there, and might take 5 hours. And that's the way I see obesity treatment, not the A to B, but many patients want A to B. They want it quickly, because it's impacting their quality of life, and they want that better quality of life now, because they've lived a lifetime of it. Of gaining, losing, not being able to play with their kids, not being able to walk, not being able to do what they want to do in their life. So they want to meet. As soon as there is any news of new medications, we get a flood of questions to our support groups. How do I get it? Where do I get it? What do I do? How can I get surgery? Why is surgery not available for me? Why is it available for you? They're seeing what treatment other people are getting, and they just want it now for their quality of life.
Thanks.
Thank you for the question and for the answer. Yeah. Yes.
No, go ahead.
Okay. I just want to add from the doctor's perspective in Germany. I think the doctors sometimes are also ruining that because they set the levels too high. Because if a patient is ready to start on an anti-obesity medication, usually the expectation for the quick fix of weight loss for the MD, for the GP, is probably also outrageous. And they often say, hey, it doesn't work with you. You have only lost 2 kilograms, but you've got 40 to go. Forget about it. And I think this is something we all also need to go.
Thank you. Yeah.
No, I wanted just to come back on Nick's question and just to share an experience with, I was alluded to this new drug, which is the MC4 agonist for patients with a genetic form of obesity, which are rare form of obesity. And I had a patient who is now been treated for 5 years with this drug, and basically the weight loss was not so good. So, but the drug had a very good effect on hyperphagia. And then I asked the patient, so maybe you are a little bit disappointed because indeed there were great expectations for weight loss with this new drug. And maybe you are disappointed. And he told me, I would never stop the drug. You cannot imagine the relief I had by being able to control hyperphagia. And I think, the patient is not here, right? So I'm just speaking for him. But the thing is, I think this, to some extent, also contribute to the discussion. This is why we need to, as you said, listen to our patient.
Yeah. And if I can add to that, I think the focus needs to shift away from weight loss and be focused on health gain. You know, so when people start plateauing their weight, they are incredibly disappointed, even if they've plateaued at 25% from where they started. But if they understand that this is a chronic disease and the purpose is long-term health gain, and we actually focus on functionality and ask patients, you know, to remember what it was like not to be able to bend over and tie your shoelaces. And then people say, I remember that, you know, and I never want to go back there. So I think that's going to be helpful, you know, when it increases the stay time, you know, and we are, of course, enthusiasts, and we want to measure as a surrogate marker weight loss, like the sugarologists like to measure glucose, right? But really, it's about the systems disease of obesity, the systems disease of diabetes, and ultimately the health gain.
But stressing the positive is what we're talking about here, isn't it? The benefits, rather than dwelling on the disbenefits.
But also getting the expectations right. And what Torsten was saying, you know, if we promise to people that they're going to become thin and happy, you know, people are going to stop taking the treatment because it turns out they're not going to become thin and they're not going to become happy. But if we say to people you're going to become healthier and more functional, you know, then you're going to achieve that. And that's the positive that needs to be stressed.
It's quality of life. We see it over and over again in the support groups where people post things like, I'm on a plane, I can do the seatbelt. You know, it fits. I can buy clothes without having to order them online. For me, I will never forget the day that I could do that again. And I'll just do it again. Because you can't. Right. And there are things that you hide from everybody. You hide how hard it is to live with obesity, mostly from your family, which is even harder because your family are the ones who are trying to help you, but they're the ones who can actually stigmatize you the most. So it is difficult, you hide it, but we just want a better quality of life, and it's about the health gains, not about the weight loss. But unfortunately, what's out there in society, especially social media, it is pushed about the looks and the, you know, you should be in a thinner body, which we've got to address that all the time.
Thank you. Let me, as we come towards the end of our session, let's do a few quick fire questions. We've had some questions from the audience. What about something I haven't heard mentioned anyway, the role of government policy or general influences from the outside, the questioner writes. Sort of nudging. What role is there for big government, if you like, to nudge the individual? Yes. Carel.
So this is controversial, but I would say, you know, we need to advocate for change in public health policy away from the eat less, move more, to just seek help. You know, if the public health message can just change to seek help, because people will find the practitioners or the general practitioners, and then suddenly they will be propelled into learning and understanding. But that may be controversial, but sensible.
But the problem is, at least in Germany, they would not recognize obesity as a disease, because then we would have too many patients, you know. And that's one of the issues why they are not really tackling it. I think your proposal is great. I mean, seek help, because in all aspects of your life, you need help, or you could need support. And we need to sort out where you would need help, you know, together with the people with obesity.
We see people saying, there's no point in me being referred to our weight management service. It's 5 years to get in. I'm thinking of going abroad for surgery. And we're not going to change their minds on that, really, to be honest, even though there's concerns. But what we say to them is, still apply to be referred to the weight management service, because you may still need it. And maybe the waiting list will change. And some of them come back, because we're doing this support group years, and they say, do you know what, I'm attending the weight management service now. Thank you for telling me to do it, because I now need it. I still need the multidisciplinary team. So.
Thank you. In early obesity, writes one questioner, without, quotes, complications, what's the long-term efficacy and viability of MNT and behavioral intervention?
So, I mean, Arya speaks very clearly about, you know, the difference. And we had a great discussion about, you know, changing the word to pre-obesity, and, you know, instead away from overweight, etc. And it's controversial, but maybe you want to share some of your ideas on that.
Well, I mean, again, you know, it comes down to the fundamental fact that, you know, you're dealing with a progressive condition, and in any progressive condition, the earlier you can intervene and halt progression, you know, that's your first sign of success. But in order to halt progression or even slow progression, I need to understand what the drivers are. I need to monitor things. We know that there are very simple things that patients can institute that will actually help slow progression. And maybe for someone who is in the early stages of obesity or pre-obesity, if you want to call it there, or Herr Miller, all he might have needed initially would have been, we just need to monitor certain things, and whether it's keeping food records, whether it's regular weighing, whether it's keeping a diary, whether it's just showing up for visits, those kind of interventions would have probably at least slowed the progression. But I think, unfortunately, what we're seeing in reality now is we're seeing patients after, at a point where we really shouldn't be patients. So every patient you see with a BMI of 60, at one point in their life, their BMI was 50, and earlier in their life, their BMI would have been 40. And the question is, why am I seeing this patient now and not 20 years ago?
And I think one thing would be also of a lot of help if we told the people, don't gain weight. Because if we always talk about the lose weight, we also cause trouble because the expectations are too high. And I had patients when I told them, hey, listen, if you can maintain your weight till the end of the year, this is already great success. And they look at me, do you know anything about treatment of obesity? My GP told me to lose 10 kilograms and stuff like that, Yeah. But I think we might help the people more if we have simple messages which they can really attain.
Thank you. Yeah. One last point, Carel. Thank you.
Yes, so, the question was also, what's the evidence that we have to treat people, with pre-obesity, etc. And the answer is that we don't have that evidence yet. We are building the evidence, but like all disease processes, we have a randomized control trial, SELECT now, that is taking people with obesity and existing heart disease and seeing what is the difference. Once we've done that and we know the answer, we move on. It's incremental. It's, we have to build. And, Rome was not built in a day, and it will take us some time, but we need to keep moving in the right direction.
Thank you very much. Now, we are a few minutes away from the end of our session, so the next thing I'd like you to do is just to revisit some of those questions. Who's had the clicker? Or could we just change on to the next slide? Go on. Right. Thank you very much indeed, Stephan. We asked you earlier that question. Could you revisit that on your Slido and say to the question, how confident are you in developing sustainable weight management plans for individuals? Well, that's a very good response.
That was just one person who's
Yeah, I know.
Only one person answered.
I'm tempted to say this is not scientific, but of course it's very top of the head. But interesting, and I think clearly on that, moving around as I speak, but with 79, nearly 80% in the very or confident department, then that sounds like a good result. Let's have a look at the next one. Weight management plans. Okay. I'm forgetting what they were. Confidence seems to have gone up, doesn't it? Yes. Yeah.
Okay.
Thank you. And this one, mental and physical well-being as part of obesity management.
Very.
There's always one quick clicker.
Yeah. Yeah, well, do we take comfort from, not comfort, but reassurance from the fact that confident or very confident is what most people seem to be answering here. And even those who are only slightly or not very, we hope that confidence grows as time goes by. As pharmacotherapies become more effective, surgery will have less of a role. Agree, disagree, agree, strongly agree.
This is your question.
Yes, that was Carel's question, wasn't it?
Oops.
There we are.
I'm not going to get invited back.
Thank you. And let's then I asked each of our panelists to have their sort of magic thought. Here's roughly what they said, and we couldn't have achieved this without a little bit of preparation in advance. Could you now, choose just one, please, of those four options. Could you say which is the one that, when you go home, back to your practice, your clinic, your surgery, whatever it is, on Monday, as I like to put it, what's the one if someone says to you, what did you do when you were in Maastricht? They'll say, well, the big message to me was, what was it? And what do we think it is? Be aware of how weight bias, your own, your colleagues, and your patients can affect patient care. It seems to be getting the highest vote at the moment.
Yeah.
What about that? Now, whose was that? Okay, but I'm sure that none of the others there would disagree with the thought either. Good. Well, I promised that we would finish punctually, and let's change on to the next slide. That's my proposal. Evaluation. Please, I did have a copy of the certificate, but I think it's been cleared away. The cleaners must have come in. Yeah, there's one. Stephen's holding one up there. So there is. They are to be had. They're beautiful pieces of high-quality certificate signed by no less person than Carel. And so you get your certificate if you're here. Please remember that there are other ways using that barcode, quick response code. Scan that for your certification. All the rest should be self-evident. Evaluation forms, please make sure that you have completed them. And it only remains for me to ask you to thank our panelists for their contributions today. Thank you all so much. To thank you for your attention and your attendance, and wish you a productive and an instructive rest of conference. Thank you.